Welcome to the Clinicians Coffee Chat on Telehealth and Diabetes. I'm Lily Catalano, and I'm a project manager for the National Healthcare for the Homeless Council in Nashville. This project was supported by the Health Resources and Services Administration, HRSA, of the U.S. Department of Health and Human Services under grant number U30CS09746, a National Training and Technical Assistance Cooperative Agreement for $1,625,741 with 0% match from non-governmental sources. This information or content and conclusions are those of the presenters and should not be construed as the official position or policy of, nor should any endorsements be inferred by HRSA, HHS, or the U.S. government. NHCHC is a nonpartisan, non-commercial organization. This is the first of a four-part coffee chat series on topics related to diabetes. We call them coffee chats because they are informal conversations, so we invite you to get a cup of coffee or your lunch and listen and discuss. This is an opportunity for all of us to share questions, ideas, challenges, and support for each other. We hope you'll share your questions and comments throughout. One of the best parts of the coffee chats is getting to hear from people doing similar work all across the country. This series was developed by the Healthcare for the Homeless Clinicians Network, which is the nation's largest network of providers of hands-on care to people who are homeless. The network helps members connect, learn from each other, and share best practices across the homeless healthcare field. If you're not already a member of the Clinicians Network, please join for free via the link in the web links box that's on the bottom right side of your screen. The Clinicians Network also has a Facebook group that's open to all of its members, and that's a place to ask questions and share successes and challenges on anything you might encounter in your work. So colleagues across the country share their expertise and experience and engage on issues related to health and homelessness. You can join the Facebook group today via the link in the web links pod also on your screen. Some instructions about how you can engage during the chat today. We want to hear from you, and we welcome your questions and your stories throughout the chat. The more you all engage, the better this chat will be. And you can type directly into the attendee chat pod on the bottom left side of your screen. Your comments will show up to all participants, and I will refer comments and questions to the panelists. So first up, let's get a little bit of a sense of who is participating in the chat today. I'm going to put a couple poll questions on your screen. The first being, what type of organization do you represent? So you can click your answer right there on the screen, and it will broadcast the results so we can all see who's participating. Are you part of a Healthcare for the Homeless program, another health center, do you work at a shelter? it looks like we have a lot of folks from other health centers, so not specifically healthcare for the homeless, and then other service providers as well. So thank you for responding. Our next poll question is about your specific role, and that is, what is your current role at your organization? Are you primarily a clinician or an administrator? Are you a government official or a policy and advocacy official? Are you a consumer or another role? And I'll give a couple minutes for folks to respond. So it looks like we have about a fifth of the attendees are clinicians and about a fifth are administrators, and then, but about 2/3 of us are in other roles. Great. And then our final poll question is about if you are currently using telehealth for diabetes care or education. So are you currently using it? Are you not, but you're planning to or interested in using telehealth? Or no, you're not using it, and at this point you don't really have any plans to implement something? Okay, so it looks like the majority of folks are not using it, but a very sizable chunk of those people are interested and planning to start using telehealth for diabetes. And about more than 20% already are using telehealth. That's really awesome, and I hope that as we get into the questions and the conversation, that those of you who are already using telehealth will share your experiences as well, and folks who are seeing this not too far down the road at your organization, please, I bet you have specific questions about what it's been like for the people who have already got some things in place. So please chime in with the things you're wondering about. So great. Before I introduce today's panelists, I want to point out a few relevant resources. Hold on, let me get that poll question out. ARcare for the Homeless Council that are available for you to download in the web links pod on your screen. We have a series of adapted clinical guidelines, and there is one on diabetes, so it's right there, that top bullet point. This was published last year, and it's recommendations for the care of patients experiencing homelessness at risk for or diagnosed with type 2 diabetes. You can access that document and other diabetes fact sheets and archived webinars via the Diabetes Resources web link that's on your screen. And then we also have a page of telehealth resources that you can access through the Telehealth Resources web link on the bottom right side of your screen. I am thrilled to tell you about our panelists today. They are Don Dericke, Lauren Faison-Clark, Dawn Springs, and Lauren Fields. They come from different organizations and are using telehealth in some different ways, and I'm really excited for us to talk about what their experiences have been like. So before we get into our discussion questions, each of them is going to tell us a little bit about their organization and the work they're doing. So Dawn, in South Carolina, would you get started and tell us a little bit about what you're up to, please?
Sure. Thank you for inviting me to be a panelist. My name is Dawn Dericke. I'm a registered nurse, and I work at the Medical University of South Carolina. I'm housed in the Center for Health Disparities Research. I've been there over 5 years, and I've been using telehealth to help study how we can help patients manage their chronic conditions such as hypertension and diabetes. And so today I'm going to be talking about a program that I've been working on for over 3 years, and it's called TACM2, and that stands for Technology Assisted Case Management, and we're helping low-income adults control their type 2 diabetes.
Thank you so much. Lauren Fields in Arkansas, can you tell us a little bit about ARcare?
Certainly. Thanks for having me today. I'm the Chief Nursing Officer at ARcare, and I enjoy the involvement in the virtual care program. ARcare is a federally qualified healthcare center, and we have 52 locations throughout Arkansas, Kentucky, and Mississippi. Our telehealth program was born mainly out of need because we had a shortage of registered dietitians, and we're in rural areas, and we had a lot of patients that had a need. So that was where we started in July of 2018. And since that time, we provide medical nutrition therapy, diabetes education, pharmacy consults. We have a school-based telehealth program in 7 different schools in Arkansas, and also primary care from clinic to clinic in the rural areas.
Thank you, Lauren. And we're also joined by Lauren Faison-Clark and Dawn Springs from Tallahassee Memorial Healthcare. We have a video that is available on your screen. The link, I don't believe, is connecting through the Adobe Room, so I don't think you can click on the actual screen to watch the video, but in the web links portion of your screen, if you click on the Tallahassee Memorial link, it will play this video for you right now on your computer. So we're going to pause for about 2 minutes to give everyone a chance to look at that video. But before we invite folks to play the video, Lauren or Dawn, is there anything you'd just like to say in introduction about your work or your organization?
So this is Lauren Faison-Clark. I know it's confusing. We have 2 Laurens and 2 Dawns, which doesn't happen very often, but Dawn and I are both glad to join you all, and we love videos because it really I think captures the essence of what we're doing. And similar to the previous speaker, we have a lot of rural areas that we serve and had challenges with access to care, and which has led us down the path of using telemedicine for lots of services. But most recently have really engaged our Metabolic Health Center and our diabetes educator in providing diabetes education to inpatients, newly diagnosed diabetics, and now we are expanding, providing those services into schools and to some of our rural outpatient clinics as well. So we are a, one hospital, community hospital. We're not part of a big hospital system, and we provide services in over 17 counties. Many of those are rural and have very low-income families with transportation challenges, and so really this has been the best way to make sure families get the care they need and that we can optimize the patient's outcomes. So I don't know, Dawn, do you want to add anything else?
That's a good intro. Okay. Thank you so much. And you all can now click the link. We'll pause for about 2 minutes for everyone to copy and paste that into your browser and watch their introduction video.
And the Metabolic Health Center inpatient side of our pediatric care. We have children diagnosed with diabetes pretty often, and they get hospitalized in the inpatient unit. And we are located in the outpatient side of the services at Metabolic Health Center. We have diabetes educators that are specialized in teaching children with diabetes and their families about how to take care of it. But that discharge. We try to make that transition as smooth as possible, but there's a lot that goes on before the patient and the family get discharged, and then they have to drive over to us or go home, and then we kind of keep going with their educational process. So we decided to use telemedicine to try and help that connection work more smoothly and to get everything started a little bit earlier in the process. So when the patients are diagnosed
in the hospital. We find out about it, and we work with the nursing staff to set up a telemedicine visit with the educators on the outpatient side. And once that time comes, we remote in, and we look at use the screens to look at the family. The family can see us. They can see the educators that they're going to meet with when they get discharged. They can have questions answered that may have been hard to get answered while they were staying in the hospital. We can talk about school. We can talk about a lot of educational issues and kind of get that ball rolling from the get-go in the hospital. And so that it's a natural step to get to the outpatient center and get follow-up education and care, and then continue on your journey there.
All right, I hope everyone had a chance to check out the video, and thanks to our panelists for giving us a little introductory information and some context about how you got to this work. But let's jump into the discussion questions. Our format today is that I'll start off with a question to our panelists and give them each a chance to answer and talk about the work that they're doing. And I'm also going to invite all of our participants to be responding as well. So after you hear the panelists start to speak, any participant is welcome to type your responses into the attendee chat. If you have follow-up questions or any points that you'd like to share or new questions you'd like the panelists to explore, you can type those into the attendee chat at any time as well. So we will go ahead and get started. So what specific services do each of you offer via telehealth? And let's start in Arkansas with you, Lauren.
All right. So at this time we offer, as I said, primary care telehealth, and we have clinics that are in very rural areas, towns less than 500, and so they can't house a provider 5 days a week. We have a front office and a nurse there, and they are able to log in and connect with a provider in another small town, and that's worked very well for the past around a year. We started that last year. And also we have school-based telehealth, and we have a nurse that's in the school, and then she also is able to connect to a provider that's in the clinic. We have diabetes education that's performed by our RN educators, and then our medical nutrition therapy, which is done by our registered dietitians. We also have behavioral health and our special services HIV program that's done via telehealth.
Thank you. What about in South Carolina?
So we have a Center for Telehealth at MUSC that helps service the whole state. The program that I run is the TACM 2 program, which is a telehealth program that has high-intensity nurse case management for patients that have uncontrolled diabetes and hypertension across the state. So how that works is we partner with federally qualified healthcare centers, free medical clinics, private practices, anyone that really wants to partner and take advantage of the service. We partner with them, and we teach their nursing staff how to enroll patients. Each patient that participates gets a meter. It's a cellular meter, works kind of like a cell phone. The patient checks their blood sugar, and they can check their blood pressure, and then these readings get transmitted to a secure server where providers can act on it. And so that's one of the biggest programs that we have at for telehealth at MUSC.
Cool. And how about in Tallahassee? Can you talk a little bit about the specific services you're offering via telehealth right now?
Well, I'll let Dawn explain what we're doing specifically for diabetes education and management, but we've really looked, this is Lauren Faison-Clark, we've looked for places to really figure out how to bring care to the bedside, whether it's in the hospital, or in a rehab unit or in a nursing home, and really trying to improve our efficiencies and effectiveness of getting those services to the patients. And in our metabolic health center, they were running into some challenges, which led us to start using for diabetes education. So Dawn, do you want to talk about what we're doing?
Sure. So we are using telehealth to help connect our outpatient diabetes education resources and team with the inpatient nursing staff and patients that are hospitalized, particularly pediatric patients with newly diagnosed diabetes or readmitted with DKA or another problem. So right now we're using telehealth to make those connections and offer those services. We're not located right next to the hospital or in the same place as the main hospital. So that's kind of a barrier we are using telehealth for. And then we are looking to expand into schools, which is another good place that we've been hearing about. And I was just talking about Arkansas doing that too. And then also in some of our rural counties to be able to offer some diabetes education and support in our clinics in rural counties.
Thank you. Can you each talk a little bit about the specific barriers and challenges that you faced as you were starting your program? I think several of you referred to it was a way to deal with location needs and particularly in rural areas, but as you were getting the program started, what did you run into that was hard or has been challenging along the way? Let's start in South Carolina this time.
Well, when we started our program, one of the big things was PCP buy-ins. The doctors at all the partnering sites, they were worried about participating in the program. Their concerns were about the amount of data that they would be responsible to act on for each patient. They were also worried about the commitment and extra burden on themselves and staff. And then to ease the burden on the primary care providers, some practices opted to develop a treatment algorithm that would empower their nurses to make the changes. However, the primary care providers, they had difficulty agreeing on one specific algorithm to use for diabetes and for hypertension that would be used for all their patients that were enrolled in the program. And then they were also concerned about how the data would be reported to them. So that was one of our biggest barriers. Personnel challenges, who would be responsible for what, unsure of who would manage the program within each site. Staff turnover is very popular at both the FQHCs and at the free medical clinics because they're based on volunteers. So training new staff on program protocol, limitations on how the program would be implemented due to each site having differences in how their staff was structured was a barrier that because each site was different and the workflow processes of each site was different. Medication titrations was a barrier and how that would be handled. We also had trouble with patients with the transmission of their readings. And then, of course, patient engagement. A lot of patients were excited, and then they would lose the excitement and they wouldn't be as engaged. So we definitely had our share of barriers in starting.
Yeah, let's hear from the other panelists as well, and then I'd like to come back and sort of dive into how you all addressed some of these specific challenges. But in Tallahassee, what barriers and challenges did you see when you were getting started with telehealth for diabetes?
Well, I think anytime you want to do something different in a different way, you immediately run into the naysayers. And I think, using technology to deliver care instead of the traditional model of people getting on the road and sending patients all over the place, it's taken us a lot of time to educate our provider community and our clinics and really helping people understand how it all works and how simple it can work. I think a lot of folks get overwhelmed by the idea of the technology and think it's going to cost a lot of money and, privacy concerns and HIPAA and how's all this going to work. And there's a lot of vendors in this space now that want to charge people a lot of money. So as I go across and talk to different programs, I see, there's just a lot of misunderstanding, and sometimes they think it's such a technology-driven thing that they're intimidated by starting. And it's really, and I'm sure Don will echo this, the technology is the easiest part. All the other pieces that the previous speaker was just talking about of the protocols and the who's going to do what when, getting people in those rooms together to really, whiteboard that and to draw a flow chart, that's the piece that really people forget to pay attention to. They focus so much on the technology that should be the easiest part of this whole process and putting it in place. There's so many different options out there now that are very inexpensive. You can just plug in and start doing telemedicine with very little upfront cost and using your current hardware and all that kind of stuff. It's helping people understand that because they tend to, they're so busy dealing with the day-to-day practice to think of something new and different sometimes can be overwhelming. But having nurse leadership and people that, having at the site that take that ownership and leadership to make it happen has really been key for us. But Dawn, I don't know if you want to add anything else.
Just one other comment on what we've encountered with the diabetes inpatient to outpatient, vice versa connections, coordinating the times of things like Lauren was referring to about the staff and who's going to do what, but really coordinating the times for the visits because it's not a super planned thing because we don't know when the children are going to be admitted to the hospital. So it's sort of a back and forth communication that has to happen between us and the nursing staff. And then because we're talking about pediatric patients, we're also trying to ensure that the parents are getting there, and the parents are usually working or juggling off who's with the patient. So that's probably been a challenge that we faced. But I think the nursing staff in the hospital has been very helpful at trying to set that all up, and then we work our schedule on the outpatient side to coordinate a time that works for them. We can juggle that together. So that was kind of a barrier that we faced that's still a little bit of a challenge, but has gotten better with the improved communication with the floor staff.
Thank you. And how about at ARcare? What barriers did you all face in getting your program started?
Well, I think I could just say ditto to what they said. 'Cause that's certainly the biggest challenge is the buy in from the providers and from the staff. Changes always scary, and this was a big change for us. A lot of our patients are elderly. Our providers, you know, worried how they would feel about it, worried that they wouldn't like it. The truth is our patients have loved it. Our staff has been the one that we kind of had to twist this arm a little bit to get them to buy in. But what we did have was a registered dietitian that had previously um, done telehealth she was able to ease the fears of a lot of people, and that was a huge benefit to us. To have someone that was familiar with that.
Uh, could, uh, programs also talk about how you kind of built support for the program over time. How did you address those concerns about having to deal with much more data and the privacy concerns and just apprehension about the technology, all the things that you referenced that kind of might have made the providers resistant to embracing telehealth?
This is Lauren. I think in Tallahassee, I think people have to see it. They have to see how simple it is, and the more you put it in front of them, the more that they are able to experience how it works and see it firsthand. I think that was one of our, biggest moments, is really educating people. Once we got through the challenges of convincing our IT staff and our compliance people, yes, this is all okay, then having the people that really are boots on the ground with the patients and the diabetes, educators are really, once they buy in and see it, they're the ones that really make it happen. So it's doing that, getting the leadership buy-in first was important for us to make sure that all the powers that be blessed, our efforts, and then really kind of sitting shoulder to shoulder with the providers and the nurses on the floor to help them see how this works, and putting the equipment in front of them and letting them play with it and experience it. And the first time they do one and they see the relief on a parent's face who's just been told their child has diabetes before they even leave the hospital, and they see that they're suddenly feel more comfortable in taking care of that child now when they go home, I think that gets that immediate buy-in, and they see the benefit to the patients and the families, and that's really been the key to keep them driving and working through some of the barriers.
Thank you. Is there anything, Dawn, in South Carolina that you'd like to add?
Sure. One of the things that we had was a pilot study research program that had very impressive results from. And so when we started looking to recruit partnering sites, we made cold calls on the phone asking if we could come visit them to just show them what we were doing. And then actually going to the sites, visiting multiple visits per site, showing them, presenting on the pilot study that we had done, showing the outcomes that we had seen and how it would work within their site. And then once we got a few sites to partner with us, it started with the free clinics in our state because the program was going to be, it was free for them to try. And once we had outcomes at those, then other sites started to want to partner with us. And then to implement that was to get the buy-in to make them say, yes, we want to partner with you. We want to do this program. Then to actually implement the program within the site, it takes so much hands-on. High tech requires high touch. If you have technology that people don't know how to use, then they're not going to use it. So making sure that the clinicians, the nurses, the assistant staff up to the providers are comfortable with using and know how to use the equipment. And they can then in turn show how the patients how to use it, because it's very easy to use. It may look complicated or seem complicated when you're trying to explain it to someone, but really making sure that they have an understanding on how to use the equipment, and then coming up with a tailored plan within each clinical site of how this is going to be implemented with the staff that they have available to make this program work. And so each site at F2HC that has 6 different clinics, starting at 1, working out the kinks, and then opening it up to the other 6 clinics. Basically just a very hands-on approach to get this implemented in each site.
Lucy Gordon, our participant, has asked, what's a realistic timeline for an organization to bring the vision to application? I'm curious how long it's taken your organizations, and if you feel like that's representative.
I'm Dawn in South Carolina. For us, getting through the red tape of legal contracts takes about 3 to 4 months from the time that a site says yes, we want to participate, to have both contracts on both sides fully executed, stamped, and approved is about 3 to 4 months. But in that time frame, we're getting all the training materials. We give training manuals, binders. We give you demo equipment so you can practice in the meantime. And we work out an implementation rollout plan from A to Z with every question answered in between by the time the date comes where you can actually enroll a patient. So about 4 months.
Thank you. What were your experiences like in Tallahassee in how long it took to get the program started?
Well, we had already been using the technology, and we had spent some of the pain of going through some of the legal pieces and getting our IT approval. With that had already happened because we were using it for other use cases. But Dawn, how long would you say till this was really up and going did it take everybody to feel comfortable with it?
I would say meeting with people and talking through the process and everything was probably about 2 to 3 months. Okay. And then I would say we're really way more comfortable after probably the first 6 to 8 weeks of using it. So yeah, maybe about 4 months total.
Yep. Great. And Lauren in Arkansas, how long has it taken y'all?
Ours has kind of been a slow process. Like I said, we started with medical nutrition therapy, so we just started with one division and then kind of grew from there. We started in July 2018, and this month we'll have over 400 telehealth visits. So that ours has been slow, but it's been pretty steady growth.
Great, thank you. And I'd love for any attendees who have been through this process as well, if you would type into the attendee chat about how long it took you from sort of starting the process to being up and running. So go ahead and respond on the screen if you're able to do that. Several of the panelists have talked about the importance of, figuring out the specifics with the staff you have and how to kind of work through all those logistics. And it sounds like the communication piece is so key up front. But I'm wondering if you all could each sort of talk us through what the setup is with which staff at which location.